Well, hello everyone, and welcome to Treat Me Right, Changing the Story for Women's Heart Care. I'm Celina Gorre, the CEO of WomenHeart, and thank you so much for spending this time with us. Before we begin, I wanted to let you know that today's session is being recorded. And in fact, you'll be able to watch the session after we end. We'll also have some time, hopefully towards the end of the session, for some Q&A. So please submit your questions at any time during the session in the Q&A button. As a reminder, this discussion is educational and not a substitute for personal medical advice from a healthcare provider. For anyone new to us, WomenHeart is the national patient-centered organization for women living with or at risk of heart disease. We support, educate, and advocate through trusted resources, peer-led support networks, and our WomenHeart Champions. We advance equitable, high-quality care in every community, and we look forward to meeting you in your community someday. Today's conversation really focuses on why women's heart symptoms are so often missed or dismissed or treated too late, and how these differences in presentation, risk, and treatment can contribute to delays in diagnosis. We'll look at what this means in real life and what each of us can do as patients, caregivers, healthcare professionals, and advocates. This event is part of our Treat Me Right initiative, WomenHeart's effort to ensure women are heard, believed, and treated appropriately when they seek care for heart symptoms. I also really want to thank the companies that have so enthusiastically sponsored this initiative. Alnylam, AstraZeneca, Boehringer Ingelheim, Lilly Alliance, Bristol Myers Squibb, Cytokinetics, and Merck. Thank you so much for your support. It really makes programs like this possible, and we're grateful that you've made this commitment to women's heart health through your support of WomenHeart. Today's discussion is an exciting one, and one that I've been waiting for some time to have. We're joined by world-leading cardiologist, Dr. Martha Gulati, and WomenHeart champion, Tanny Coward. And now, over the next hour, we're going to frame the issue of missed and delayed diagnosis, explain why it happens, highlight specific risks that affect women more often than men, and discuss where progress is being made. So there is some good news there. We'll then move into solutions and what effective collaboration can look like in a clinical setting. In other words, between you as a patient and your healthcare provider. We'll also hear from the patient perspective. Tanny Coward will share her story. And then at the end, we'll take questions and close with hopefully some clear next steps for you, some actions that you can take, and some actions we can all take together to improve care and diagnosis for all women. So let's jump right into it, and I will introduce Dr. Gulati. You probably need some introduction, but I'm going to do it anyway. Dr. Gulati is the immediate past president of the American Society for Preventive Cardiology. She's the professor of cardiology at the Smith Heart Institute at Cedars-Sinai in LA, and is the director of prevention, the associate director of the Barbra Streisand Women's Heart Center. Hooray for women's heart centers. Not a lot of them out there, and holds the Anita Dan Friedman Endowed Chair in Women's Cardiovascular Medicine and Research. She was formerly the inaugural chief of cardiology at the University of Arizona, and she is the author of the best-selling book, Saving Women's Hearts. She also has served as the chair of the first national chest pain guidelines for the American Heart Association and the American College of Cardiology. I will also add that Dr. Gulati is a former board member of WomenHeart and a current member of our Scientific Advisory Council. It is such an honor to have you join this discussion today, Dr. Gulati, and we're looking forward to learning from your expertise. So let's start with big picture. How often are women's cardiac symptoms missed, or how often is the diagnostic process delayed in your experience and kind of in the literature more generally?
Well, thank you, Celina. Thank you for having me here, and thank you for WomenHeart for continuing to lead the charge, trying to help our women actually be heard and hopefully in the future get treated right. I mean,
Yes.
really that is all of our goals, and I think it's just so great to every time when I hear Women Heart, I'm always very happy that this conversation continues. So I think this is one of the biggest issues, right? Is that first of all, with women's symptoms, regardless of what they are, for whether it's a cardiac condition or otherwise, women are much more easily dismissed.
Yeah.
We're talking about pain, other physical pain or chest pain. Both of them, the first question often to women is the question of, are you stressed? You're stressed? Are you anxious? What's going on at home? Not to say that those things aren't important, but we're all under stress, men and women, and
Yeah.
we all are dealing with our modern world of craziness. And I think that the question should always be what you would ask men first. Like when you hear especially the words chest pain, don't ask men if they're stressed out or not. They're probably stressed too, but we don't ask them that question. The first thing that goes through a physician's mind or a healthcare team member's mind is, could this be heart disease? And why the same response is not the case for women will all continue to shock me, because we hear all these stories. We know that women are much more easily dismissed. They're under-recognized for heart disease at all ages. I mean, younger ages and older ages, we still discount their symptoms. We still think of heart disease as a disease of men, even though it's the leading killer of women. And even, when we talk about breast cancer, where women even recognize they're at risk for, you're 10 times more likely to die from heart disease than you are of breast cancer. Not to minimize breast cancer, but just to put it in perspective.
Right.
We know when women do present, though, that there's delays at every stage. We have data of younger women under the age of 55, who go to the emergency room. They are less likely to be seen in a timely manner. In fact, there's about a 10-minute delay between men and women who all have chest pain. I'm not talking a different symptom. I'm talking presenting with a symptom that we consider very important. And commonly present when there's something going on with the heart. So women, there's a 10-minute delay. Women are less likely to receive an EKG or to be put on telemetry. And women are less likely to be seen by a consultant like a cardiologist. And therefore, they're less likely to be admitted to the hospital. So why are we surprised that women don't do as well if we don't take their symptoms that seriously? That we somehow think that a delay is okay. Once women get sort of in that pathway, okay, now we've made you a diagnosis, we realize you're having a heart attack, well, there's still delays. Women are less likely to be taken to a cath lab to receive an angiogram to look for a blockage in a coronary artery, if that's what we suspect. If we think, if they're having a heart attack, that's usually the way that we treat it. But women are less likely, and if it's, whether we talk about the door to balloon time, the time from entry to the hospital to the minute that they open up your blood vessel, or we talk door to needle time, where they give you a thrombolytic, because some hospitals will do that instead, especially in our more rural communities. Again, longer for women compared to men. And even after we make the diagnosis of someone having a heart attack, we still are less likely to give them the life-saving, guideline-directed medical therapy that every man and woman deserve. Just by being a woman, we're less likely to give those therapies. And women are more likely to be readmitted. Women are less likely to be sent to cardiac rehab. So why are we surprised that women are more likely to die? I mean, honestly, of course they are. These are the things we've been struggling with for over 2 decades, saying that, look, this is what's happening, and repeatedly presenting the statistics showing that this is happening. And still, we have not been able to close these gaps. They're getting slightly better in some parts of the world, but not everywhere. And I think that there's still a huge gap to really recognizing a woman's symptoms. Part of it may be that women present a little differently. But even when women present exactly like a man, we still discount their symptoms. And if you want, we can certainly talk about the differences and the similarities. I don't know if I'm talking too much, so I apologize.
No, you're fine. You're fine. We'll get to the actual symptoms and sort of the differences there. But I wanted to dive a little bit more deeply into, you said that we see delays at all levels and at all stages. Is there something that stands out to you where you say, the ER is really where we see the greatest difference, or like the care after diagnosis is really where the differences are remarkable? Or are we just sort of saying it's bad everywhere and we just really need to pay attention sort of to the comprehensive journey for every woman?
I really think it is comprehensive, and I'll tell you why. Because yes, it happens in the emergency room. It even happens before that in the ambulances that show up at people's houses. It happens once they're in the hospital, even when a cardiologist is involved and decides, okay, well, you're having a heart attack. Who's the one that writes the prescriptions when you leave the hospital? It's the team taking care of you. You can't blame the emergency room for that.
Mm-hmm.
Who sent you to cardiac rehab? It's the doctors taking care of you.
Mm-hmm.
And again, that's likely my community. I'm going to take the blame on that because I think it's everywhere. And so I think, and then even if we move past a heart attack, if we go into heart failure or the TAVR devices or any other disease, atrial fibrillation, transplant, we see women being treated different in all those different diseases, where they're treated less aggressively, that they're less likely to receive the latest and greatest in technology that is changing and revolutionizing what we can do in our cardiovascular world. But we don't offer these lovely novel therapies in the same way to women as we do men. It's not fair, it's not appropriate, and it's how we lose lives.
And what would you say, Dr. Gulati, are some of the top misconceptions, whether that's coming from the patient perspective or the clinician or society at large, perhaps, that that kind of like result in these delays?
Well, I think there's a lot of different misconceptions. I'm not sure. Let me think of. So I think from a patient standpoint, I would say I know that the people that belong to WomenHeart probably are more aware of symptoms and things like that because they've gone through this journey themselves.
Yeah.
But if you think about yourself at the earliest part of your journey and what you might have known or not known, I think women, though, have never, many of them will tell me after they have a heart attack or after they have a heart diagnosis, they will say, nobody ever told me to worry about my heart. They were examining my breasts, my uterus, bikini medicine, we're really good at it, but nobody ever talked to me about my risk for heart disease. How could you stare me in the eye and say you were at high risk when nobody else said that to me before?
Yeah.
So I think that for patients, I think for women patients often it is the case. I think that from a healthcare standpoint, I think still the biggest misconception out there is that young women cannot have heart disease, or that women can't have heart disease. And yet every one of our WomenHeart members, it will beg to differ that women can't have heart disease. Of course they can have heart disease.
Absolutely. Absolutely. And would you say that there are particular groups that are at even higher risk? Women are at risk because of all the things we've talked about, but within the group of women, are there folks that are at even higher risk that tend to drive this inequity?
Yes, I think that the group in the United States that is at the biggest risk is Black women. We always say it's worse to be a woman, but it's worse to be a Black woman. The reason I say that is because of the disproportionate risk to people who are Black. There's more risk factors in the community, but there's also worse social determinants of health that ultimately influence our physical health. And
Yeah.
additionally, even to compound on top of that, is just like I told you that there's a bias about women in general, about undertreating them, that bias is only amplified when you're a Black woman. The undertreatment, all the things that I told you about, are even further augmented if you're a Black woman. So I think that group really needs, we need to be more conscientious as a healthcare community,
Yeah.
caring for patients that are from Black communities and being able to be a trusted source, because of course there's a long history in the United States of not trusting our medical community, which
Right.
is founded on real reasons.
Yeah.
But we need to be partnering with our community and with our patients in a way that is acceptable to them, but also to be able to make it clear that these risks are present and how can we mitigate them. Because heart disease, much of heart disease, not all of it, much of heart disease though is preventable, but we have to be there. We can't, I think where we are right now in the healthcare system is we're meeting people when they have an illness. We're not really upfront trying to prevent it. And I always say that we do sick care really well. We don't do health care very well. We don't preserve health. We treat you when you're sick. America's really good at treating the sickest people. I'm a preventive cardiologist, and my goal is really to think about how can we prevent heart disease and how can we do it more upstream. And that's going to take a lot of work for all of us, and particularly, like I said, I think for our Black patients, this is something that we still need to have partnerships in our community so that we can really make inroads. And I think the other group that I would say also, just to add, I don't think it's as, it's not related to necessarily always to social determinants of health, but I do think that South Asians have a very high risk of heart disease, so that's another unique group that seems to have some genetic basis for a difference in their risk, even when they don't look at high risk on the traditional biomarkers. And then a third group I would say is immigrants in general. I think there is a lot of stress being an immigrant, especially right now in our country, but just being an immigrant, there's a lot to deal with, a lot of different stressors, a lot of less family support when you come to a new country, on top of the changing diet, because McDonald's is our diet. We're an example of a diet in the US, and it's hard. And I think that's another group that we need to watch out for, because I think wherever you come from as an immigrant, there is different stressors in life that can also aggravate cardiovascular risk.
Absolutely. And just on the point about these different groups, having particular risk, what is your view on representation, right? Because we know, for example, that is it something like 14% of cardiologists are women? So there's that aspect of representation. But then also when you break it down into ethnic groups and racial groups, there's another facet, right, of representation there.
Absolutely. And I think the reality is if we looked like our patients, like our medical community looked like our patients, we would take better care of our patients. And I think certainly within the cardiology world, it's been dominated predominantly by white men. And I think that there's been a lack of women, but there's also been a lack of diversity at all levels.
Yeah.
Certainly in the leadership roles and where people make the priorities or are the decision makers, really even within our community, that still predominantly is men. We're changing it. Of course, one of our members of WomenHeart, Dr. Rosen, is now the American Heart Association president, which is fantastic.
Fantastic, yeah.
Next year, we will have, as our ACC president, will be Dr. Roxana Moran. So that things are changing,
yes.
but we still have to grow and diversify so that we look like the people we care for. and understand. I mean, it's not that I have to look the same as Tanny to take care of Tanny, but maybe I've worked with colleagues who help me understand her culture and where she's coming from so that we can better relate and understand where she's coming from and be able to not just make blanket statements or even recommendations that will not fit in her lifestyle. And if someone understands that you understand where they came from, I think you're more likely to connect and be a more trusted voice. And so by having a diverse workforce, by having diverse colleagues, we learn, because we even have evidence that when men work with a lot of women in the emergency room, they take better care of women who present in the emergency room having a heart attack compared to men who work in a male predominant emergency room. So there is something to be said about diversifying our workforce.
Absolutely. That improves quality of care broadly. So let's dive a little bit into, we alluded to this earlier, into the symptoms. What are some symptoms that women present with that might be considered uncommon or atypical? And what might those lead to in terms of misdiagnoses?
Well, first of all, if I can correct you,
yeah, please.
You might know that I hate the word atypical.
I do.
And when I wrote the chest pain guidelines, we actually asked our medical community to stop using that word. And the reason that we asked for them to stop using it is because although atypical does mean presenting differently, right? The way it's got translated in the medical community, honestly, when people use that word, they usually mean benign. Like if they come and say, oh, this person has atypical chest pain, it means they're not going to work it up. Women, first of all, are 51% of the population. Our symptoms are not atypical. We are the majority. So our symptoms are actually the common symptoms. So I just want to try to change our community's way of talking and even our public's way of talking.
Yes.
So we put that into the guidelines. So I always want to make sure that that gets out. But I will say that, you know, one thing to be clear about, because we do want the public health message to be that if you're experiencing chest pain or chest pressure, that is the commonest symptom that people experience with a heart attack. And that doesn't matter if you're a woman or a man. We have lots of data. We have a study from the Virgo study, which is a study of young women under the age of 55. And they showed that 90% of women and 90% of men actually reported chest pain before their heart attack. And interestingly about that Virgo study is that when more women saw their doctor before their actual heart attack, like just in the outpatient office, and were told that their symptoms were less likely to be cardiac, versus men who were seen in the ER. Then we have a study called the high stakes group that's of all ages of men and women. And again, in that study, they showed again 90% of women and about 90% of men had the symptoms that we would consider the usual symptoms of a heart attack. And even when we use AI, when we listen in using some cardiolinguistic technology, we have evidence of exactly the same thing, that if you take away bias and you just let a computer record what it hears, 90% of men and women will say the words chest pain or chest pressure. But the difference between women compared to men is women are much more likely to report other symptoms. And chest pain may be only one of many symptoms they're experiencing. And it might not even be the most important symptom that they're experiencing. So it's important for us to recognize that when you have neck pain or jaw pain, if you're having back pain, arm pain, even in the absence of chest pain or chest pressure, or profound fatigue, or shortness of breath, those are potential symptoms of cardiac disease and potentially of a heart attack. So we do want women to take those also seriously, and we want, of course, our healthcare community to recognize those accompanying symptoms as important to be asking about, and understand that women will describe more than men. We don't just use one word to describe anything. So why would we do that with our chest discomfort or whatever we're experiencing? Because we are good at, women, I will say, more than men, every month in our adult life, every month we know our body's changing. We usually can tell, the onset of a period. We know everybody has their own personal signs. We are much more in tune with our bodies. So
That's right.
it's also not surprising to me that women are in tune when something's wrong, and they will describe what they're feeling. And we do need their symptoms to be taken seriously.
Yeah, absolutely. And on that note, can we talk about things getting better? We talk about sort of, moments of or good causes for some optimism. What are we seeing now? What's being done now, where we're seeing some measurable, if modest, improvements?
But we are seeing some closure of these gaps in terms of, once women have a certain disease, in terms of getting more women on adequate therapy. So that's one area that's getting a little bit better. I think that the other area, we just actually published a paper, and I just presented it at the European Society of Cardiology just last week, I guess. It's so long ago. But we actually looked at research, because we've been saying for a long time that women have not been included in research. And we analyzed more recent data to see, has there been any change? And in this most recent decade, we can see that there is an improvement in the inclusion of women into trials. Particularly, I would say, in heart failure trials, they were the worst before, meaning the lowest enrollment of women. And I will say that they've almost achieved equity, not fully, but pretty darn close, of getting women into the big trials, that clinical trials that have happened recently. Where we still have the gaps, though, sadly, are with ischemic heart disease, acute coronary syndromes, like all the stuff we've been talking about, having a heart attack. Those studies have still lagged far behind. And any of our interventional trials where we're putting in a device, I will say that women are less likely to be included. And so I do think it's important for the women listening, just if you're ever asked to be on a trial, remember, we're only going to learn about us if we participate. And I know sometimes the problem is we don't even ask women as well to be in trials, but if you get asked, think about it, reflect on it. Of course, it may not be for you, but certainly consider it, because that's how we're going to save the next generation. We really need to design our trials in the healthcare community. We have to design our trials to be the type of trials that women will enroll in, and be thinking about them up front when we're designing the trials. What would make a woman enroll in this trial? What would make it easy for them to continue along in this trial? Because women are busy people. They're usually taking care of, if not their children, their elderly parents, their partners. We're the caregivers. We know that when we make studies a little bit more pragmatic and easy, with less in-person visits, or more, maybe even completely virtual, people are much more likely to be in those trials. Our women specifically are much more likely to volunteer to be part of that.
Absolutely. And at WomenHeart, we've got a project called Enact, which is focused exactly on what you're talking about, not just encouraging women to be in clinical trials, but just giving them a broader view of what it means to be in a trial and what they can expect. So we're really trying to help that cause along as well. So let's just talk about, in the last couple of minutes here with you, some solutions and thinking about ways to collaborate. So for both patients and providers, what would you say? How should they think about approaching kind of this diagnostic journey, so that they're more likely to get an outcome that they deserve?
Yeah, I think it's very important for us to have a good rapport with our patients. Like, it's a two-way street, right?
Yeah.
We can, as physicians, it's one thing for me to give information, but if my patient leaves not understanding any of it, I haven't really done my job. So when you're finding a physician, if you have a cardiac condition and you're not getting answers, or you don't feel like you have any time for questions, or they don't allow questions, and I've heard all of the above. You know, I'm not saying that it's the wrong physician, but you know, maybe even make an appointment and say, can I make an appointment just to get all my questions answered because we were dealing with this acute issue in this. If that's not acceptable, then I think you might need to find a better partner on this journey. You should be able to ask the questions that you don't understand. You know, people always, my patients will always say, oh, I know this is a stupid question, but I want to ask it. I'm like, there's no stupid questions. You did not go to medical school. Like
That's right.
We do not leave high school with health literacy. Sadly, I wish we did. We do not leave knowing everything, or at least enough even to communicate with our doctors. There's things that I will have patients find out, some, you know, just random things where they're like, I never knew that. And, you know, things that we take for granted. And so we must understand that our patients are coming, you know, they've never had anything wrong with them, or they've never had a heart condition wrong with them. And suddenly we're throwing things around like stents and statins and Plavix and this and that and pacemakers, whatever we're talking about. And I'm like, whoa, what's happening? Like, I don't even know what you're talking about.
Yeah.
We have to make sure that our patients understand. And I would beg of our patients, our members of WomenHeart, to really don't feel like you can't ask. If you feel like you can't ask, you're not with the right person. You should be able to ask, and you should not feel stupid at all, because this is not something you've dealt with before. Understand your medications. Why am I taking each one? You might end up after, say you have a heart attack, you might end up on 5, 6 new medications to you. Ask with each one, what's cover? What will it do to me? What's the benefit? What's the side effect? And, you know, what are the things I should be looking for while I'm on this drug? Will I feel a difference, or is it one of those drugs that I'm not going to feel, but it's actually doing work? And I think, you know, the best patient to me is the ones, I know they always apologize when they come in with their list of questions, but I love it because I love that they feel like they got every question answered. I see them check them off, and I'm like, okay, good. Like, they're leaving feeling empowered and feeling like they know what they're doing now, because it's a partnership. I can't be there to shove pills down your mouth. Only you can take those pills, right? So I think when patients better understand why we're doing what we're doing, and it's a shared journey, they are much more likely to be compliant. Because the one thing about the heart that I think is overwhelmingly the issue, unlike a lot of other organs, you just don't see the heart and you really don't feel it until it's a problem. You know? And so that's why it's kind of the silent thing. Like, we can talk about hypertension, but you can't see it until it's a problem. Cholesterol, the same thing. Like, you know, that's the hard part. If it was something, even when your bowels, for example, like we do think about our bowel movements. So maybe that is something that we would actually like, oh, that's not right, something's going on. But the heart is very much hidden. And I think that is something that makes it even harder, that we have to spend time with our patients so that they understand, whether it's prevention, whether it's secondary prevention after you've had a cardiac event, that you understand. Ask for good reading resources, and even ask if you can come for a visit where you just get your questions answered. And also bring in a partner, because sometimes, especially early after a cardiac event, it's all overwhelming. You're hearing all these new medications, all these things they want you to do. Okay, eat better, exercise more, go to cardiac rehab, take these 10 medications, here's the different times. By the end, you're so overwhelmed that you might have picked up one thing out of the 10 things they told you. So have a partner, a loved one, a friend, a family member come with you, because it's not happening to them. They can be a little bit more detached. They can be writing the notes, and they can even be your voice. Like, okay, how does she take 10 pills in the morning? Like, you know, or, you know, whatever the issue is, they can help you through the journey. I think that those are tools that I tell people. I don't ever think that a family member should not be involved. You know, when people, I've heard this actually, where certain doctors don't want a family member in an office, and that is not acceptable.
Right.
You sometimes need an extra set of ears. And then even for some of our older women, if their ears don't work all that well, it is nice to have a family member or a loved one or someone else in the room to actually make sure that everyone heard it right.
Yeah, some great tips, I think, for patients and for providers in terms of, allowing your patients to ask all the questions that they have. I think that's really critical. And it's a good litmus test to see whether that's the right provider for you. So thank you for that, Dr. Gulati. We're going to transition over to invite Tanny into the conversation. I'd like Tanny to share her story, but first I want to give you a little bit of background about Tanny. Tanny is a WomenHeart champion from Houston, Texas. She completed the Science and Leadership Symposium at the Mayo Clinic in 2020. And since then, she's been working hard to support women in her community and raise awareness about how heart disease might look differently in women. Tanny is currently also an esteemed member of the WomenHeart Champion advisory team and has been there to support other newer WomenHeart champions in their journey to become champions. So Tanny, thank you so much for joining us. Let's talk a little bit about your experience and what getting a diagnosis has been like for you. Can you walk us through your a brief timeline of your journey, including the symptoms you felt and how you decided to go and get some help and get some information about what might be going on with you?
First of all, thank you for having me. It's been
Absolutely.
a pleasure just listening to the doctor because she definitely was on my doorstep several times. Surprisingly, my journey actually happened or started about 20 years ago, unbeknownst to me.
Wow.
I worked in an environment where I had to get a tuberculosis test every year. And I took the tuberculosis test and it came back suspect. So we had to go get a chest x-ray. I remember clearly getting the chest x-ray and the young man that was doing the chest x-ray asked me, "Ma'am, can you breathe?" And I just thought that was a weird question for him to ask me. So I was like, "Yeah, of course I can breathe. Yeah, why are you asking me that?" And he kind of dismissed it. And I did not dismiss it. It stayed in the back of my head. I did go to my primary care physician and I asked her, "Hey, can you pull up the x-ray results from my tuberculosis test?" I remember the technician asking me, could I breathe? And I just thought that was a weird question for him to ask me. And she said that she looked up the results and she was like, "No, you're fine. The only thing you need to do is lose weight." Now, the reason that I kept going back to my primary care physician is because I had gained quite a bit of weight. I was having acid reflux really bad, and I was having a really hard time breathing. And I kept going. I probably was going to her maybe once a quarter with these symptoms because they were very bothersome. Now, what she told me was, okay, you have acid reflux. That's normal. You are gaining weight. You are the age of menopause. So you are supposed to gain weight. And her response to me was, you just need to lose weight. And that was her answer. You need to lose weight. So, of course, I'm going to the doctor. I'm checking myself out. And she's telling me what I want to hear. And that's that everything else looks fine. You just need to lose weight. I started playing golf. I was very active, but the weight was not coming off. And I was still having a hard time breathing. Fast forward 10 years, I wake up gasping for air. I literally went to work one Friday, woke up Saturday morning gasping for air. I got up, I went to urgent care because, of course, I went to Mr. Google and I self-diagnosed myself and I thought I had an upper respiratory infection. So I went into the urgent care thinking they're just going to give me some antibiotics and I'm going to be on my merry way. The doctor at the urgent care, he asked me could he do an x-ray because he did the put the stethoscope to my chest and I saw a kind of funny look on his face. And I was like, yeah, whatever you need to do. He did do the chest x-ray, and then he asked me, did I drive there alone? And I was like, no, I did not. My husband drove him. He said, well, can we bring him in here? And I'm thinking, this sure is a lot for an upper respiratory infection.
Yes.
So he did bring him in, and he said, we need to get her to a hospital ASAP. I will allow you all to transport her. However, I live in a little suburb of Houston, and he was like, I don't think you all need to go to one of the boutique hospitals out in this area. I think you need to take her to the medical center. And once I stood up, I felt fine. I just still had a hard time breathing, and I could actually feel like rattling. So I'm thinking, okay, maybe pneumonia. So we go to the hospital, and I did, to be honest with you, I was very reluctant about it, but my husband was insistent, like, no, we're not going to wait until Monday, because that was my answer. Let's just wait till Monday. I'll go back to my primary and see what they say. Because my primary pretty much had brushed it off and told me I was going through menopause, had sent me to an OBGYN, and they were basically doing a follow-up for menopause.
Wow.
That's exactly how I was being treated.
Yeah.
So we did go to the ER. Then once we got to the ER, they did give me my x-ray on a jump drive. And the doctor at the urgent care said, hey, give this to them when you get in there. So I walked in, he parked the car, I gave it to him. And the lady at the desk, she looked at the x-ray and she looked back at me and she was like, did you walk in here on your own? I was like, I did. And she was like, well, let's redo the x-rays because something's not right about this. They redid the x-rays and then they put me in a room. When I knew something was serious is when she came back to me and she had these papers, and the papers were, if something happens to you, do you want to be resuscitated?
Oh my goodness.
That's when I knew, okay, something is really serious here, because I think that's a really serious question to ask somebody that has an upper respiratory infection. So they actually did admit me into the hospital, and I would say 5 or 7 days later, my memory is a little cloudy with that. I felt 100% better. The doctor that was there, which was not my primary doctor, this was the on-call doctor. He said, everything looks good. We've gotten a lot of fluid off of you. I just want you to see one more doctor. And if that doctor says everything is okay, you can go home. All I heard was, everything is okay, you can go home. I got up, packed my bags. I was ready to go. The doctor comes in. And I noticed on his jacket it said cardiologist. And I thought, that's strange. You know, I'm ready to go home. And he started asking me about my family history. He said, tell me about your dad. I said, well, my dad died at 45 from a massive heart attack. He said, tell me about your brother Winfred. He had all of my medical history because, of course, I'm very upfront and honest in sharing my medical history. I know heart disease ran in my family. I shared that with my primary doctor. She was well aware of these things, but I was never given a workup for heart disease. Never. Wow. And so, of course, I gave him all of that information. He said, well, I want to do a few more tests on you. You will not be going home today because if my thoughts are correct, you have what we call familiar congestive heart disease, congestive heart failure. And I mean, my whole world just shook at that moment because I'm like, are you sure you have the right person? Because I feel so much better now. And he explained to me, you do feel better. We've taken 36 pounds of fluid off of you in 7 days. So you should feel much, much better. However, we're going to do some tests on you and we'll let you know exactly what your condition is. 2 or 3 days later, he came back and did let me know I have systolic and diastolic cardiomyopathy. I have congestive heart failure, and at that time, my ejection fraction, my heart function was 12%.
Wow. Wow. That is, what a story. And looking back, what do you wish you would have known something different about advocating for yourself and all of it sounds like you saw multiple providers through your journey, and each one of them would have been an opportunity or could have been an opportunity to investigate further. How do you think about advocating today, thinking back to you know, who the patient sitting in that hospital room?
To be honest with you, my thought was this: I'm going to the doctor, I'm doing what I'm supposed to do, and they're the experts. They're telling me that they're looking at my test results and that I'm fine. I did not feel like there was anything major wrong because, like I said, you know, they would give me medicine for acid reflux. I would feel better for a couple of months and then I wouldn't. They were telling me what I wanted to hear. Now,
Yeah,
what
yeah.
I know now is that I'm a bulldog when it comes to advocating for myself. If I feel something's not right, I'm immediately saying, hey, we need to check this out. This is
Right.
actually the reason why I'm a Women Heart advocate today.
Awesome. And if somebody was listening today and was feeling the same way, feeling dismissed, feeling overlooked, thinking, "Ooh, have this symptom," what would you say to them? How would you advise them?
What I would say is they are the experts. They are, but they're not the experts of your body. If you feel something's not right, just like the doctor said earlier, ask for a sit down and ask them to listen to the symptoms that you're saying. And then once they hear the symptoms, give you a complete answer to each one of the symptoms. Don't just pat it away. And I actually allowed them to pat a lot of my symptoms away. And they actually did give me a diagnosis. They told me I was in menopause. I was. And they told me that I had acid reflux. I did. However, those were underlying factors to my congestive heart failure.
Yeah. And so, Tenny, we have spent a lot of time together. You are an amazing advocate in your community. You use your story to really raise awareness about heart health, women's heart health in particular in Houston and surrounding areas. What drives you to spend your days doing this work, to share your story? And what change do you hope to see in the work that you do?
What really drives me is the fact that I am African American and I didn't see anyone looking like myself once I got diagnosed telling me that there is help out there, that there is someone that can stand aside, stand next to you and help you with some things. And once I got diagnosed, I was still by myself. I went 2 years looking for a support group. I did not find a support group. One day, and I kept looking, I was on the internet and I stumbled across Women Heart. I signed up for a big sister. My big sister is Judy Parker. I have to say hello to her. She is
Yes.
amazing. She connected me, and she lives in Florida. She connected me with the Houston chapter, which is Kim, which is my superwoman.
Yes.
And I walked into the meeting. It was exactly what I needed. I walked into the meeting. Kimberly was there, and she was actually there by herself. There was no one else that day for that support group meeting.
Wow.
Kimberly sat there and took the time and let me cry for an hour because
Amazing.
it was finally a relief. I had found my person. I had found my place. And once she explained to me what Women Heart was, I was like, wow, I need to be in this place. Now, it was not my plan to sign up to be a Women Heart champion. I honestly was going there because I needed a champion myself.
Yeah. And here you are doing that work for others. It's an incredible story. Tanny, thank you so much for sharing your powerful story and the perspectives that you've shared with us.
My pleasure.
So now I want to open it up to our audience to see. We've got two questions in the Q&A. Please add your questions to the Q&A, and I'm going to start reading them. First question here from Susan Boddicker. How can we train doctors? I think this is for Dr. Gulati. How can we train doctors and medical students to be more alert to women's symptoms and more likely to treat them? Dr. Gulati.
That's a great question, Susan. And I think one of the most important things is that we really need to be in all medical school curriculums. I mean, I think that it's not the case right now. That may surprise a lot of you. Some medical schools have made it a priority, others have not. I've been told at different places where it was a special interest group to teach people about sex differences. And so we still lack that idea that it must be part of the medical school curriculum. The next generation needs to come out and know this. And that, I know that, Celina, you congratulated Women's Heart Centers, which is great. We wouldn't need Women's Heart Centers if everybody was taking care of women equally to men.
Totally.
And the hope is one day we won't need them. But right now, in this current era, we do need people, we do need women's heart centers to really be the place where the expertise lies, and also to do the studies and the trials that need to be done on women so that we
Yes.
really can understand them. So I think that that's where it starts, but it of course doesn't end there. We of course try to do a lot of educational programming for family physicians, internists, cardiologists, really everyone, so that they understand and know the difference between men and women and the similarities and where the gaps in care are. I think it's also important that we continue to measure, and nationally and even on a local level, to know, are we taking equitable care of women as we are to men? And then adjust our strategies if we find we're not. We shouldn't be embarrassed if our numbers aren't good. No one's numbers are good.
Yeah.
But we should be able to make, just like we try to do quality improvement programs in hospitals for specific issues, quality can begin with just saying, are men and women being treated equally?
Absolutely.
There's a lot of different places that we need education, but I think, again, right now it's across the continuum.
And I would add, from the patient perspective, having women's heart centers directs patients to places where they know they can get good care. If you have been, striking out in different offices and with different providers across the country, that's something that Women Heart's trying to do. We are in the process of building a directory of women's heart centers across the country so that women can find providers that they know this stuff and will believe them.
Exactly.
Right.
Okay, moving on to Robin Peacock. Are you seeing a shift in the male doctors as the old guard ages out? Meaning, are the newer male doctors more open to an engaged patient as a partner in their care?
I think so. I mean, first of all, I do truly believe that the medical community is changing. Although there's only 14% women cardiologists, there's actually 20% women in training right now. And so that's a very good sign that more women are entering our field. And that's been years of work for many of us, trying to get more women excited about cardiology and understanding that our doors were open to them, even though we didn't necessarily always look like them. So I think that it is changing. I think as a result, male doctors are learning more. And we actually even have some male doctors involved in women's heart centers and male doctors who study women. And so I don't think that this is just a female doctor only type of specialty. In fact, we try to encourage young men to come into our field very much, and even at our own Women's Heart Center here at Cedars-Sinai, we've had many male fellows come out of our training program, and I think that makes them more sensitive and more understanding of how women differ compared to men, and have a greater appreciation. So I do think that, and I also think that there's been more discussion in the last 5 years, particularly about shared decision making and understanding that the patient is a partner and the most important part and central to their care. And rather than it being, I'm going to tell you what you need to do, it's going to be a discussion of what are your values, what is important to you, how, here's the evidence, but here's what you care about, and we come together at a place that a patient is comfortable. I think that's what it means to have the patient as a partner. And I do think there's been more emphasis about that in the cardiology community particularly. So I hope that means that we're all changing how we talk with patients, how we communicate, and how we together make decisions.
That's such a great answer, Dr. Gulati. And I often talk about how we should not conflate women cardiologists with women's heart health. I think that all too often we kind of mix all of that up into one soup, when the reality is, for example, the interventional cardiologist that diagnosed me is a man, and is just as passionate about this work and this field as you are, and and other women cardiologists. So I really love this idea that we need to be encouraging all cardiologists to be taking up this specialty, and recognizing that there's a need to study it as a specialty. I see Barbara. Barbara, you have a question about arterial plaque, and it's a question about are endocrinologists and primary care providers trained about the threat that arterial plaque can have to somebody's health. I think this is like a calcium score question. It's saying, yeah.
I can take that question.
Yeah.
She's asking about, just because you don't have elevated cholesterol,
Yes,
do physicians understand that you can still have plaque? I think yes and no. I guess as a cardiologist, I'm always thinking about plaque, and then maybe our endocrinologists are thinking more about blood sugar, and our primary care has a lot of things to think about. So I don't know that it's a specialty specific, but I do think that we are increasingly looking at plaque to assess risk. And I think, risk assessment starts with putting in your traditional risk factors, and now we've expanded that risk score to even include things like your urine albumin creatinine ratio, which a lot of people think has to do with your kidneys, but actually has a lot to do with your heart. And even BMI, body mass index, is also in the newer prevent risk score. But then it helps us decide based on what we see, should we do additional imaging? And yes, you can absolutely have plaque despite not even having high cholesterol. Because, of course, there's another risk factor that most women, I think every woman should know about, is their LP little a. And if you don't know what your LP little a is, get it checked. It's a simple blood test. Elevations in LP little a are really common. 1 in 5 women have elevated LP little a. And it actually, uniquely for men, it's kind of steady throughout their life, but for women, actually after menopause, it slightly increases, and it's important to recognize that. But that could be a reason that we'll find plaque in the arteries despite having quote unquote normal cholesterol. But certainly for our patients who have diabetes, it can be very useful to look at plaque. Again, this is something that you decide with your physician, but again, to be honest, anybody can go and get their plaque checked, because coronary calcium testing, you can just walk in and get it done. So
yeah.
I think it can be a very useful tool to help us with risk assessment before you actually have a cardiac event.
Thank you. And then Cheryl wants to know, do you have any advice on how to speak about your own women's heart attack symptoms if we find ourselves in the ER thinking we're having a heart attack?
If you think you're having a heart attack, you must say those symptoms. You must say those words aloud to scare the ER physician or the ER team. Just say, do you think I'm having a heart attack? So that at least they do the right blood work and they do an EKG. That's where we're missing women, is because they don't do the EKG or they don't do the blood work, and they tell you you're just stressed and send you home. Ask them, because when you ask them, it'll make them pause. It will make them at least do that test. And then if they're normal, you're probably fine to go home. Maybe you still need an evaluation, but it won't be like an acute thing that needs to happen in the emergency room. It's scary when you experience symptoms that you think could be a heart attack, and you shouldn't leave till you know with certainty that your heart is okay.
Thank you so much. There are several more questions, and I'm sorry we don't have any. We are almost at the hour here, but we will note your questions and get back to you with some answers. I just want to say thank you so much to Dr. Gulati, to Tanny Coward, for spending some time with us, enlightening us, teaching us, inspiring us, and sharing your wisdom and your experience. I'd like to end with having each of you give us one sentence that what would you like anyone on this webinar tonight to take away, or one action you'd like them to take. Let's start with Dr. Gulati.
Oh, I was going to let Tanny.
Oh, Tanny, sure. Go Tanny.
Okay. I think I said it earlier. The doctors are the experts, but they are not the experts of our bodies. And if you know something is off, be very, very vigilant until you get the answers that you're comfortable with. Don't leaving without the right answers.
Great advice.
I,
Dr. Gulati.
I agree with Tanny on that. I think it's trust your heart,
Mhm.
because really, when you feel something's wrong, you know, find the answers. If someone's not answering it, find another person, another doctor to see. Don't take it's all fine or it's normal. And for those of you that don't have heart disease, make sure you know if you're at risk for heart disease, because the more you know, the more empowered you are to be able to change things.
Thank you so much. Thanks again, Dr. Gulati, Tanny, and thank you to our audience. You've been really amazing with your questions, super thoughtful and super engaged. So this Heart Talk is part of our Treat Me Right series. It's really our effort at WomenHeart to ensure women are heard, believed, and treated appropriately when they seek care. To keep learning and take action, please visit womenheart.org to explore our campaign and also to perhaps recommend this webinar to your friends and family. As we finish up, one small ask for each of you to take action, and that is whether you're a patient, a caregiver, a professional, healthcare provider, or advocate, choose one action today to help improve care for women. Start a conversation about heart disease, learn about how symptoms present in women, or share this webinar, as I said, and our Treat Me Right tools with someone who could use them. Take care, everyone. Thank you for joining us, and we look forward to seeing you at the next Women Heart event. Bye-bye.
Bye bye.